Okay. Good evening, everyone. So, welcome to the block of the month. So, today we'll speak about ultrasound guided popliteal sciatic nerve block. Popliteal sciatic nerve block actually is a very easy block, and the only issue with this block is the anatomy. So, if you can understand the anatomy, then it gets much easier. The whole ultrasound guided nerve block. So, as we all understand that the sciatic nerve arises from L4, L5, S1, S2, and S3. So this is the view if you see from the front, and that is the sciatic nerve, which is in pink in color, and it comes out from the sciatic, greater sciatic, notch. So that is how the sciatic nerve is formed. Then we need to understand the anatomy of the sciatic nerve. The following structures which passes through the greater sciatic notch or foramen is the piriformis muscle. And the structures passing above the piriformis muscle is superior gluteal vessels and the nerves. And the structures passing below the piriformis muscle is inferior gluteal vessels. That is shown here. That is the blue and the red color, the sciatic nerve itself, the pudendal nerve, the posterior cutaneous nerve of thigh. These are the things that passes through the below the piriformis muscle, and that is the pink color is the sciatic nerve. Fine. Now coming to the yeah. So the popliteal fossa, which we have read during our anatomy days, the popliteal fossa is a diamond-shaped space that lies posterior to the knee joint. That is lower part of the femur and upper part of the tibia. So these are the boundaries that we need to remember. And let me play this. So inferior medially by the medial head of gastrocnemius, that is shown here, the highlighted areas. That is the lateral. So infralaterally by the lateral head of gastrocnemius. Then superior medially by the tendons of the semitendinosus and semimembranosus. So remember, the semitendinosus is the outermost and the semimembranosus is the innermost. So that is on the both the sides, which are highlighted in yellow. Then superior laterally, there is tendon of biceps femoris. So that is what it is shown here in this. That is yellow in color, and the same thing on the this side of the leg. So these are the boundaries that one must remember. Then the popliteal fossa, what happens is the sciatic nerve descends vertically down. It lies deep to the bicep femoris and semitendinosus muscle, and it terminates by dividing into the terminal branches, that is the tibial and the common peroneal nerves. But where it divides, it's quite variable. It can divide anywhere from 5 to 10 centimeters from the popliteal crease. So coming to the tibial nerve, it extends from the superior angle, that is from here, the superior angle to the inferior angle of the popliteal fossa. During its descent, the tibial nerve crosses the popliteal vessels from lateral to the medial. So the common peroneal nerve, which is a very small component, which I will show you the pictures, which is highlighted here in pink. So the common peroneal nerve extends from the superior angle to the lateral angle of the popliteal fossa along the medial border of the biceps femoris muscle. It then winds around here, winds around the posterolateral aspect of the neck of the fibula, and it pierces the peroneus longus muscle and then divides into superficial and deep peroneal nerves. So the course of the tibial nerve is terminal branch of the sciatic nerve. It lies deep to the gastrocnemius and soleus muscle, and it lies on the posterior surface of the tibialis muscle. And the course of the tibial nerve, to continue with that, the tibial nerve accompanies the posterior tibial artery. At the level of medial malleus, it lies medial to the artery and lateral to the flexor hallucis longus tendon. Under the flexor retinaculum, in the foot, it divides into the medial and the lateral branches. So if you see the branches of the tibial nerve, You need to remember this. It has a superficial muscle group and a deep muscle group. The superficial muscle group, it supplies the gastrocnemius, plantaris, soleus, and popliteus. And the deep muscle group, tibialis posterior, flexor hallucis longus, and the flexor digitorum longus. The branches of the tibial nerve in the leg are like the sensory branches, that is the sural nerve, the medial sural cutaneous nerve plus the lateral sural cutaneous nerve. It enters the foot between the lateral malleolus and the calcaneum. The lateral calcanean branches like lateral side of the foot and the little toe. The lateral dorsal cutaneous nerve provides the cutaneous innervation to the lower posterolateral surface of the leg. And the medial calcaneum nerve close to the ankle supplies the skin of the medial surface of the calcaneum and the heel of the foot. So that is where the blue part that is shown there. And the tibial nerve, again, it has articular branches. So it supplies branches to the knee joint, superior and inferior tibiofibular joint, the ankle joint. And the terminal branches are like the medial plantar nerve, the lateral plantar nerve. The medial plantar nerve, it runs deep to the abductor hallucis muscle. The medial proper digital nerve supplies the grade 2 and the three common plantar digital nerve further divides supplying the nerves from, toes from 1 to 4. So there are muscular branches also. The intrinsic muscle of the foot, like abductor hallucis, flexor digitorum brevis, and flexor hallucis brevis. And the cutaneous supply would be the anterior two-thirds of the medial sole and the medial three toes, including the nail beds of the dorsum. Let us see about the lateral plantar nerve. The lateral plantar nerve runs deep to the abductor hallucis muscle. It crosses the soleosis, crosses the sole of the foot between the flexor digitorum brevis and the quadratus plantae. And it reaches the lateral compartment of the sole and divides into the superficial and deep branches to supply. The motor branches, quadratus plantae, the flexor digiti minimi brevis, adductor hallucis, dorsal and plantar interossei. The cutaneous innervations are anterior two-thirds of the lateral and the lateral one and a half of the toe that is shown here in the green color. The common peroneal nerve, as I told you, it has superficial and deep branches. The superficial peroneal nerve originates within the substance of the peroneus longus muscle, and it then descends first between the peroneus longus and the brevis muscle, runs across the intermuscular septum of the peroneus brevis and the extensor digitorum longus. So this is a little bit of complicated, but then you have no option to remember. This could be asked in the exam. If it then pierces the deep crural fascia and becomes cutaneous in the lower part of the leg. So this is very important to remember. After piercing the deep crural fascia, it divides into medial dorsal cutaneous nerve, the intermediate dorsal cutaneous nerve, which has the motor supply and the sensory supply. The motor supply peroneus longus and peroneus brevis muscle. Sensory supply the skin of the lower anterolateral aspect of the leg. Then the deep peroneal nerve. So we'll come to the deep peroneal nerve now. The deep peroneal nerve originates within the substance of the peroneus longus muscle of the lateral aspect of the proximal fibula. Then the nerve travels medially and pierces the intermuscular septum, enters the anterior compartment of the leg. So within the anterior compartment of the leg, it accompanied by the anterior tibial artery. That is, always remember, the arteries will accompany the nerves, and it descends in the plane initially between the tibialis anterior and the extensor digitorum longus. Now, during its descent, the deep peroneal nerve is initially lateral, then anterior, and then finally medial to the anterior tibial artery. So this is in relation to the artery where it is laterally, then anterior, and then again medially to the anterior tibial artery. So coming to the deep peroneal nerve, again, it travels under the extensor retinaculum. It then divides within the dorsum of the foot into two branches, the lateral branch and the medial branch. The lateral branch supplies the intrinsic muscle of the foot, that is extensor digitorum brevis and extensor hallucis brevis. And the medial branch supplies the skin of the web space between the first and second toe. If you see here, the pink color that comes almost near the ankle and then it divides into lateral and the medial branches. That is what I was trying to tell you. Are there any variations in the sciatic nerve? Yes, definitely there are variations in the sciatic nerve. There is type 1, type 2, and type 3 variations. Let us see that. So the type 1 variation, which is normal pattern, 84% of population will have this. The entire sciatic nerve, that is a tibial plus the common peroneal components, passes below the piriformis muscle. The maroon color that is shown here is the piriformis muscle and the yellow is the sciatic nerve. Now, what is its clinical importance? This is this is the usual anatomy encountered during ultrasound guided subgluteal or popliteal sciatic nerve block. Coming to the type 2 variation, in this kind of variation, you see you see this in 11% of the population. The common peroneal division pierces the piriformis muscle, while the tibial division passes below the piriformis muscle. So the clinical significances may predispose to piriformis syndrome due to the nerve compression during gluteal or parasacral blocks. This variation, this variation can alter nerve visualization or block efficacy, and this may increase the risk of incomplete sciatic nerve block if injection is not proximal enough to this division. So that is the one yellow branch is the peroneal passing through the red piriformis, while the other is the tibial that runs below the piriformis muscle. That is what we need to remember. And the type 3, that is 3% of population, the common peroneal division passes above the piriformis. Oh, sorry, I've already spoken this. I don't know why I called. Okay. The other rare types is the Biton and the Anson. Type 4, the entire sciatic nerve passes through the piriformis, and the type 5 is one division above, other through the piriformis, and type 6 is like entire nerve passes above the piriformis. So preferably, probably about less than 1% in each of these cases. Now, if you go through few of the studies, the anatomical variation of the sciatic nerve in relation to the piriformis muscle, 51 cadavers, right, that is 102 lower limbs in total, were examined for the collection of for the data. 89% had normal anatomy, 8.8% had two variations, and the rest had three variations. So the division, as I was telling you, the division of the sciatic nerve, that is anywhere between 5 to 10 centimeters is normal, but in few literature it says about 5 centimeters to 18 centimeters above the popliteal crease, where it can divide into the common peroneal and the tibial branches. High division of the sciatic nerve is seen as high as in pelvis, and sometimes trifurcation of sciatic nerve may occur with additional muscular branches to soleus muscle. Right. So they also studied the efficacy of sciatic nerve block for pain management in below the knee orthopedic surgery. So what the study came up was almost 93.4% did not require any rescue analgesic up to 18 hours after surgery. So single shot sciatic nerve block provide effective pain relief to majority of the patients up to 18 hours in below knee orthopedic surgery. So this is what we need to keep in mind, and it's an excellent block for these procedures. So the block is used to provide anesthesia for leg, foot, and ankle surgery. Analgesia following knee surgery can also be used. There are a couple of approaches: the lateral approach and the posterior approach. The Popliteal, again, these are again just to refresh our anatomy, memory. Again, this is the just the anatomy. I'll jump the slides coming to the popliteal sciatic nerve block per se itself. So there are two approaches. One is posterior approach and one is lateral approach. This is the posterior approach where the patient lies in prone position and where you put place a probe and see the tibial nerve and the popliteal vein and the popliteal artery. If the patient can lie in prone, well and good. Otherwise, it's very, very difficult. Before we go into the what you call anesthesia, giving anesthesia or performing an ultrasound guided popliteal sciatic nerve block, it is important to understand the osteotomes, myotomes, and dermatomes of this. So these are the few, osteotomes and dermatomes. This I have taken from the NYSORA. So this is what we need to keep in mind. Now, how do I do it? So it is important to do a scout scan. So what is scout scan? It's a pre-interventional scan should be performed to identify the femoral nerve in the inguinal area to optimize the ultrasound image before the intervention. No matter how it is, always perform a scout scan before you put in a needle in there. There are few different ways of covering the probe here, but what I have done is this is the other way of covering the probe. I've taken a gloves and covered it with the, I mean, put some jelly in that and covered it with the jelly and put a band across the probe. So this is one way, and I will show you the other way of doing. Now, if you see here, there's a sleeve cover,
Yes,
and
sir.
this is the ergonomics that I'll be following. That's a sleeve cover, and I put a tegaderm there and perform the block. And make sure that the block point and the ultrasound machine are in the same line.
Yes, sir.
Fine. So now this is called as the arrangement. Whenever you put a probe exactly in the on the crease of the popliteal fossa, you see a hyperechoic structure with the two hypoechoic structures. Sometimes, because of the probe pressure, you may only see one hypoechoic structure. So this is nothing but the tibial nerve, the popliteal vein, and the popliteal artery. So whenever you put a probe where the orientation marker is placed laterally, so this is the image that you see, and the arrangement of tibial nerve, popliteal vein, and the popliteal artery is called as the snowman in the back. So they refer to this kind of a snowman in the back. So the hat that you see on the snowman is the tibial component, that's the vein, and the bigger one is the artery. So this is what has been described. So if you actually scan here in this particular image, you see this was done in 2013. So in 2013, we were using M turbo machine, and there are two components of the common peroneal nerve, and there is one tibial nerve. Always remember the tibial nerve is bigger than the common peroneal nerve. Sometimes, not very common, but you can see the common peroneal nerve getting divided into two. So that is one. So this is not very commonly seen, but it's a bit rare, but we do definitely come across. Now, sometimes this is what the arrangement I was trying to tell you, the snowman. Sometimes see here, the tibial nerve component is here, the common peroneal component is here. That is the vein that is getting compressed, and this is the artery. So nerve, vein, and artery that you see. This arrangement is known to be the snowman in the back of the knee. That is what has been mentioned. So laterally, you have bicep. So this is lateral and this is medial. So the laterally you have biceps femoris and medial you have semimembranous and semitendinous muscle. So this is very, very important because this is a very, very basic block, and all the fellows should be able to answer this or should be able to show when asked in the exam. Right. So this is the common peroneal component and this is the tibial component. As I told you, the tibial component is bigger as compared to the common peroneal component. So this is the one. So now this, how do you know this is vein? Obviously it gets compressed and the artery does not get compressed. Now there is something called pendulum maneuver. So what is pendulum maneuver is this. So what happens when you come when you go away or come, when you go up and down the popliteal fossa, the common peroneal nerve comes and meets the tibial nerve. So this coming and going away is called as the pendulum maneuver. This is the other video to just to show. See, this is the tibial component. This is the common peroneal component, and this is called the pendulum maneuver, where they come together and go away when you move the probe. Fine. Now, how do we identify? Many a times in patients who are obese, sometimes it gets difficult to identify the common peroneal component and and also the tibial component. So we do something called a seesaw sign. What is seesaw sign? It's nothing but the dorsiflexion and the plantar flexion of the foot will elevate the tibial and the common peroneal nerves respectively. So it forms like a seesaw kind of a movement, and this can help, or it can help us in identifying the common peroneal component and the tibial component. Now, if you see here, let me play these two videos. If you see here, so I'm placing stops. So whenever he moves the leg, the tibial component goes dorsiflexion and flexion. So the tibial component goes up and the common peroneal component goes up. This is nothing but the seesaw movement. So this you should know, and this is definitely helpful when you are doing what you call in a obese patient, when you're scanning in a obese patient. So there is something about the word about the effective local anesthetic volume in adults. If you're using a ropivacaine 0.2%, so 9.3 ml is the minimum. So low concentration, good for analgesia. Mind you, this is good for analgesia, not for anesthesia. Zero point 0.5 and 0.75. We use 0.75. We use anywhere between 15 to 20 mils. So ultrasound guided popliteal sciatic nerve block, about 16 mils should be good. And surgical anesthesia level also is very good. And in general, adult single injection, again, anywhere between 10 to 15 ml. That is what has been said. I don't use adrenaline containing solutions because we had a case where the sciatic nerve has intraneuronal arterioles. So when you're using the adrenaline containing solutions, they tend of kind of getting into spasm, and the the block is prolonged for a longer duration, causing some kind of a worry in the patient. So we try and use, at least I try and use 0.75% ropivacaine. So how we do needling? Again, the needling, as I've said here, it's a art of needling that one should be able to precisely pierce the layer that you intend to pierce. What I mean by this is very simple. Again, this is again in 2013. The video is taken. If you see, my needle is very close to the nerve. I'm just above, and it's, the already there is some drug is being deposited in the paraneural sheath. So what you see is small, those white structures when the drug is going, those are all the small minute air bubbles. So this is one that you need to create. This is also called as the donut sign. So again, one more demonstration of sciatic nerve block here. So I always use in plane because it gives me a sense of satisfaction, but you can use out of plane as well. So in plane, advance the needle tip just to pierce the paraneural sheath. How do you know that you pierced the paraneural sheath? You just feel a pop that may be felt, right? So the common paraneural sheath or the subparaneural sheath, it's a loose facial sheath external to the epineurium, but enclosing both the tibial and the common peroneal divisions together. So this is the ideal target for local anesthetic deposition, in the sense when the nerve is just about to divide, you can give at the division, and it acts faster and it acts better. So local anesthetic should be injected inside the common paraneural sheath, that's the subparaneural or the subepineurial compartment, but not intraneural, that is intrafascical, where you see this white hyperechoic structures. So this is also called as subparaneural injection, or the paraneural compartment injection, or subepineurial compartment injection. So these are the various names that has been given to this. So if you see another video here, how do we do it? Simple. So I get my needle very close, I get that pop, and I ask my assistant to give the drug, and this gives me a sense of completeness of the block. So the drug should be at least covered three sides of the nerve. That is what it says. So first inject 1 to 2 ml test dose. So to confirm that there is a circumferential spread, then inject the full volume, typically about 15 to 20 mils of 0.75% ropivacaine in our case. Fine. Another video. So this is how exactly a donut is created. So almost all the sides, what the hypoechoic area surrounding the nerve is the drug which has been deposited, and it is almost covering all the areas of the, I mean, all the sides of the sciatic nerve, and this is nothing but the donut sign. If you see here again, yes. Fine. So why now the question that is very see, this is another important thing that you need to keep in mind. If you see here, when I don't see the needle tip, I think at this point of time, let me pause it. At this point of time, I feel this is the tip of the needle, but actually when you see that needle is overshot, then I have to get the needle back. So that is why I was trying to tell you, it is very important to it is very important to see the needle tip while giving the injection, right? Because other thing what I wanted to tell you is the vein that you see here, and particularly not in this particular case, but otherwise it's a low flow state. So what I do is keep the probe there, press the calf muscles, the vein opens up. So you know that there is a vein there. Otherwise, you may deposit the drug into the vein and you may see last. Now, the next question that comes into mind is why inject inside the paraneural sheath? So, studies have shown that the faster onset drug directly baits both the division like the tibial and common peroneal. Longer duration, the sheath acts as a closed compartment, retaining the local anesthetic around the nerve as long as possible. More complete block ensures spread of both components even before bifurcation, and less local anesthetic volume. So the effective with anywhere between 15 to 20 mils instead of 30 mils used in the older techniques. So this is the other study that says that the subparaneural injection accelerates the onset and the increase the duration of sensory blockade compared with circumferential extraneural injection. And as I told you, the effective dose that is ED90 for a subparaneural injection was 8.9 ml in this particular study. So, so the other thing is, the other study that like ultrasound guided sciatic nerve block in below knee amputation surgery, subgluteal versus popliteal. So, which is better, whether to give subgluteal or whether to give a popliteal sciatic nerve block? So, this was a prospective, randomized, interventional, double-blinded study was done in patients undergoing effective below knee amputations to compare the effectiveness of subgluteal versus the popliteal approach for blocking the sciatic nerve. So patients in the popliteal group had 100% success rate, shorter time to perform this block, lesser overall complications, and required no post-operative rescue analgesia. So ladies and gentlemen, it is a very simple block. I think every fellow who joins fellowship in regional anesthesia should be able to perform this block within a month's time of joining. So to summarize, regional anesthesia, regional anesthetic blockade of the sciatic nerve can be performed through multiple approaches, and ultrasound guidance has become the standard of practice. Newer crosswise approach to popliteal sciatic nerve block can be performed without altering the limb position and without much technical difficulties. But crosswise approach is not my purview of this topic. So precision in anatomy, perfection in needle placement, and respect to the nerve sheath, that is the art and the science of an effective popliteal sciatic nerve block. So thank you so much for your kind attention, and thank you. Let me stop.